Hi everyone, welcome to our webinar today. Happy Wednesday. I hope that you're having a great day and a great week. We're excited to share a webinar with you today. It's Attentive Healthcare Solutions on how to earn a positive incentive using NextGen HQM. My name is Chelsea Grover and I'm the Marketing Communications Coordinator for Attentive. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention this webinar will be recorded. We'll send out a copy of the slides along with the recording within the next week. Next, for those of you who aren't familiar with Attentive, I wanted to share a bit of who we are with you. We specialize specifically in next-gen healthcare, and we're passionate about providing solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything next-gen, and we also have add-on productivity solutions for next-gen, ChartGuard, and Refund Manager. If you haven't heard about those, let us know. We'd love to tell you more. Next, I wanted to mention that on October 17th, we'll be presenting Balancing Reports in PM. In NextGen PM, Why Don't Your Reports Match? In it, we want to examine and share helpful hints that we've discovered on why reports don't always balance in NextGen and steps to take to avoid this irritation. Join us for that. We'll send out a webinar invite for it a week before the webinar. Okay, so back to today's webinar on using NextGen HQM to earn a positive incentive. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them, and again, questions may be entered in the questions box. So now, without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is our Healthcare Compliance Consultant, and Lexi DeMarsh is our Managing Consultant. So Lindsay, I'm going to hand it off to you. Feel free to get started when you're ready.
Great. Well, thank you, Chelsea. Hi, everyone, again, and thank you for joining us for our webinar, How to Earn a Positive Incentive in 2018 Using NextGen HQM. Now, we're all aware no one wants to leave free money on the table when it comes to incentives in the healthcare arena today, but the truth is many practices are. With the second year of the Quality Payment Program underway, providers have a low threshold to meet to not only avoid a penalty, but also at the chance to earn an incentive payment. So as a result, we wanted to provide a one-stop shop for you all for everything you need to know to earn a positive incentive in 2018 using the NextGen HQM to report under MIPS and also the Medicaid Meaningful Use Program. And we wanted to provide you this information before the last 90 days of the year so you have time to plan and get organized and implement a strategy. So specifically on today's agenda, we're covering the topics I received the most questions about, starting with the MIPS requirements. We will just be going over the reporting requirements for each of the 4 categories under MIPS, so you're familiar with what you need to report on and the scoring methodology. I'll make sure to highlight specifically any changes from last year's reporting, one of which is actually the name change from ACI, or Advancing Care Information, to PI, or Promoting Interoperability. I have actually had a number of clients concerned that this was an entirely new program introduced in 2018, which is not the case. It's just a name change for this category. So we went from MU to ACI to PI in 3 years. So believe me, I understand the confusion surrounding this. But besides the name change, we also have the option to report on 2 different measure sets in this category, depending on your EHR version. This has also been another big area of confusion, and we plan to go over it in detail, not only what's required, but the new measure set changes and how it will actually affect your workflows. We will then look at the HQM specifically, at the settings to ensure your practice is set up and starting out on the right foot for 2018, as well as how to run reports and analyze them for your performance. And then lastly, we're going to take a very brief look at the 2018 changes to the Medicaid Meaningful Use Program within the HQM. Essentially, I'm taking you through the ins and outs of what I do for clients when I assist them with their MIPS or Medicaid Meaningful Use reporting to give you a better idea of how to evaluate your performance and better position you for a positive incentive in year 2 of this program. One thing I will point out before we even get started is for those of you who participated in MIPS in 2017, last year, I'm going to ask, have you logged into CMS to check your 2017 final score and performance feedback? I'm hoping a lot of you are shaking your head yes. If not, this is critical. The payment adjustment you'll receive in 2019 is based on the final score. And I can't stress enough how important it is for you to check your MIPS feedback score. And even if you answered yes to that question, we actually have some updated information for you. If you've already checked your final score, you actually need to log back in and recheck it. CMS just released information last week that they found errors in their scoring methodology and adjusted everyone's scores accordingly. So to recap, CMS will not send the information to you. You actually have to log into the Quality Payment Program portal that's on that website to access your MIPS 2017 final score and see your performance feedback. And that's even for those of you who submitted using the NextGen HQM last year, you have to log into the QPP portal using your CMS credentials. All right, so back to year 2, focusing on 2018 reporting under MIPS here. We're going to go over what I call the basics on a what you need to know basis for 2018, starting with eligible clinicians. For the 2018 MIPS performance year 2, there was no change in types of clinicians eligible to participate. Now, I point out specifically that there was no change because next year, in 2019, this list of clinicians gets expanded to include more types. There's been some confusion if they would be included this year, but CMS has confirmed these are the only eligible clinician types for 2018 that you see on your screen. The next piece of need-to-know information is the low volume threshold, which determines if clinicians can participate or if they're exempt from MIPS. So there has been a change to the low volume threshold for 2018 to include MIPS clinicians billing more than $90,000 a year and Medicare Part B allowed charges or covered professional services under the Medicare physician fee schedule, and furnishing covered professional services to more than 200 Medicare beneficiaries a year. This is an increase from last year where the thresholds were only 30,000 and 100 patients, and as a result should exclude more providers from the program this year. Now, keep in mind the low volume threshold is applied at the level in which the clinician is going to participate in MIPS. So really what that means, if a clinician is participating at the individual level, the low volume threshold is determined at that individual NPI level. For any clinicians that are participating as part of a group, that low volume threshold doesn't change and it's determined at the group or TIN level, not that individual level. This means that if an individual is not over the threshold, but the group they are a part of or that practice is, they may want to consider group reporting in order to get the maximum number of clinicians included if they expect a positive adjustment. On the flip side of that, if your providers are exempt on an individual level and they're maybe poor performers, you may want to report as individuals to get a higher positive adjustment for your high-performing providers that way. It really just depends on the practice. Now for the 2017 performance period, the low volume threshold calculations were based on all Medicare Part B allowed charges. However, since the Bipartisan Budget Act of 2018 was enacted in February, this actually included a change for these calculations to base them on covered professional services under the physician fee schedule. Essentially, this means that it will no longer include charges for Medicare Part B drugs. So you can actually check if you're above that low volume threshold by going to the QPP website and using the NPI Lookup tool there to check your participation status. This Lookup tool is actually a resource and is found on qpp.cms.gov, and it essentially allows any clinician or even their office staff to type in an NPI and determine if a clinician who bills under Medicare is eligible and should count on participating in MIPS. The tool reflects eligibility for clinicians based on their clinician type and also their Medicare enrollment date. It also includes their eligibility for each practice association or each TIN they're associated with based on that low volume threshold calculation, as well as any information on special statuses. So if you're a provider actually practicing in a health professional shortage area, a rural area, or if you're maybe hospital-based or ASC-based, these are things that'll show up here. And really, this is the very first thing I do when I work with any client. I type in every NPI the practice has to figure out if they're even included in MIPS and any special statuses they may have. This is important, especially because unlike last year, CMS did not mail out any letters notifying practices who was eligible with the low volume threshold change. So last year you may have received a letter telling you which providers were eligible and which were exempt. They no longer did that for this year too. Also with the low volume threshold change, with that actually getting a little bit higher, more providers will be excluded. So you really want to make sure you take the time to go ahead and check your NPIs here. Currently, the Lookup tool displays information from the first determination period, and that's actually from September 1st, 2016 through August 31st, 2017. This tool will actually be updated to reflect information from the second determination period later this year. So essentially, CMS reviews your historical claims data from 9/1/16 to 8/31/17 to make the initial determination. If you're determined to be exempt during this review, you will remain exempt for the entirety of the year. CMS conducts a second determination for performance period 9/1/17 to 8/31/18. And don't worry, if you were actually included in the second year and you were found to be over those thresholds, you'll remain exempt for the year too. So all in all, if the Lookup tool indicates a clinician isn't eligible for MIPS at the individual or group level, the eligibility status generally won't change at the practices displayed on the tool. There are going to be some exceptions here, mainly if a clinician joins a new practice. They have a new TIN NPI combination here that could change, but that's really the only place that that would actually change. Now, if you look at the screenshots provided, this is how you determine if you're included or exempt. One of the photos on the left-hand column should show under your provider's name. If it's that first photo there, this actually means that you're exempt at both the individual and group level, and you don't have to participate. And you can see that, I mean, it says exempt right there, and it's also grayed out versus in that green font there. The next one down basically shows you if you were exempt at an individual level. So if you were under that low volume threshold as an individual, but as a practice or the group you're associated with was above that threshold. If they choose to do group reporting, you may need to participate. And then lastly, you can see here with that screenshot, this clinician is included both at the individual and group level and will need to participate no matter what. So once you determine you're eligible and went ahead and viewed that status on the QPP website, you should understand how you actually get to your MIPS final score. And how this works is there are 4 performance categories that make up your final score. And your final score is what determines your payment adjustment. So these categories are quality. This replaces the old PQRS program. This essentially is based on performance measures, and you pick the 6 measures that best fit your practice. The Promoting Interoperability category, I mentioned, CMS renamed this from the Advancing Care information. This is essentially, the name change was to better focus on patient engagement and electronic exchange of health information. What we really refer to this category as is replacing the Meaningful Use program. And then we have the Improvement Activities category. This actually includes an inventory of activities. The inventory allows you to choose activities that are most appropriate to your practice, and they have different categories to choose from, such as expanded practice access, maybe even care coordination, etc. And then lastly is this cost category. This performance category actually replaced the value-based modifier program, and it actually is calculating the cost of the care you provide, and it's based on your Medicare claims data. 2018 is the first year this performance category will count towards your MIPS final score as well. So you can also see here, I included the weight of each category that's contributing to your final score, as well as the reporting period required for 2018. You may notice, if you're familiar with the program from last year, improvement activities and promoting interoperability weights and reporting periods did not change from last year. However, the quality category changed the most. It went down in weight to accommodate the addition of the cost category. and it actually went up in reporting period length from 90 days to 1 year. And then lastly, to really round out the basics of what you need to know are the details surrounding your MIPS final score. So this final score is compared to a threshold to determine if you receive a positive, negative, or neutral adjustment. For 2018, that threshold is only 15 points. And as you can see from the points breakdown displayed on this graphic, anything under 15 points will earn you a negative payment adjustment of up to 5%. Anything over 15 points could be a potential positive adjustment, but once you hit over 70 points, you're actually eligible for the exceptional performance bonus. And that's really the goal I set for most clients. And then thanks to that Bipartisan Budget Act of 2018 we talked about earlier, the payment adjustment will not apply to Medicare Part B drugs or services that are not covered professional services. All right, so with the basics covered, I just wanted to go over briefly each category to remind you of the requirements and point out any changes. I honestly just took these slides directly from CMS since they do a good job of summarizing what you need to know without all the additional information that may not concern your practice. So first up is quality with a weight of 50%. Providers must select 6 measures, and one of those measures must be an outcome measure. Now, if an outcome measure isn't available or maybe it doesn't apply to your practice, you can select a high priority measure. So some changes this year include any measure that does not meet data completeness criteria will only earn 1 point. Previously, last year and this first year, you could earn 3 points. That is going to stick around if you're part of a small practice. And if you're a small practice, that means you have 15 or fewer clinicians. So you'll still get that 3 points. But really the main takeaway here is reporting 6 measures with 1 outcome measure, and you're actually required to report on that for a full year. Next up is improvement activities. This counts for 15% of your final score, and there's no change in the number of activities required from last year. You still want to achieve 40 points. You have medium-weighted activities that are worth 10 points, and you have high-weighted activities that are worth 20 points. And these just require a simple yes to attestation. However, with these self-attestation measures where you're just saying yes, you do need to make sure that you have the appropriate documentation to support it if CMS were to ever come back and question you. And then just some special considerations here. Again, small practices, you only have to achieve 20 points in this category for full credit. So that's really only reporting 1 high-weighted measure or 2 medium-weighted activities. And then for practices with the PCMH recognition, you automatically receive full credit in this category and you don't need to do anything. The only change here from last year is that the threshold to be deemed PCMH under MIPS, last year you only had to have 1 practice site, there really wasn't a threshold to get full credit. For this year, they've specified that 50% of the practice sites need to be PCMH recognized. And if you're wondering how CMS is defining practice sites, for this PCMH determination, there is a little asterisk underneath that box that explains they're defining practice sites as the practice addresses that are available in PACOs. The third category and brand new this year is the cost category. It's going to count for 10% towards your final score and include just 2 measures, the Medicare spending per beneficiary and total per capita cost. These should sound vaguely familiar. They were used in the value-based modifier program prior to MIPS. So originally the cost category would have been set at 30% of the final score next year, but thanks to the Bipartisan Budget Act of 2018 I mentioned before, it did a lot for us. We now have the greater flexibility in setting the cost performance category weight for 3 more years. So essentially it's allowing CMS to offer a more gradual transition to help clinicians become more familiar with this category. So happy we got a little break here. We will most likely see this category stay at a relatively low weight instead of jumping right up to 30% next year. And then the last category we will look at before diving into the HQM is actually this Promoting Interoperability category. So here's a look at a brief overview of the scoring in place for 2018. First off, there are 2 measure sets available to choose from based on your EHR edition. This has caused the most confusion, I think, for clients and will be what we focus on next. Other than that, there's really no change to the base score requirements for 2018. For the performance score, MIPS clinicians and groups will actually earn 10% for reporting to any one of the public health or clinical data registry reporting options as a part of the performance score. So this is no longer just immunization reporting. They expanded that measure. So if you're reporting to a specialized registry, instead of just getting bonus points in this category, you'll now get 10 out of 10 points towards your performance score. On that same note, they are keeping that bonus score around, so there still is a 5% bonus for reporting to an additional registry, not reported under the performance score. So if you think back to the old meaningful use program, you actually had to be in active engagement with 2 public health registries. If you kept both of those around, you're going to get 10 points towards your performance score as well as an additional 5 bonus points in this category. And then an additional improvement activities are eligible for a 10% promoting interoperability bonus just for completing one activity. And this is important. I encourage most of my practices to do this, especially using NextGen. It supports a lot of the activities that require that certified EHR technology functionality. And it's a pretty easy 10% bonus here by just attesting yes to one of the specified activities. And now for the actual cert requirements. Clinicians can use either 2014 or 2015 certified EHR technology or a combination for this year. The 2015 cert, which is 5984 for NextGen users, is not required until 2019. However, there is a 10% bonus available for using only 2015 edition cert in 2018. So something to keep in mind. So to look at this in more detail, there are 2 measure sets providers can report on for this year. Which one you report on really depends on your EHR version. So the 2018 objectives and measures can only be reported on if you have 2015 cert, which means NextGen users, you would need to be on version 5984. The 2018 transition objectives and measures are the same as last year and can be reported on no matter which version of EHR you're on, either 2014 or 2015. So on the left-hand side in both images are the stage 3 or 2018 measures divided up by base score on top and then performance score on the bottom. And on the right are the 2018 transition measures, which you should be familiar with if you reported last year. The base score requirements are very similar, as you can see, between the 2 measure sets, with the addition of the request accept summary of care document added to that stage 3 set. And again, just a reminder for the base score, you have to actually attest yes or have at least 1 in the numerator to get any credit in this category at all. The performance score requirements for 2018 measure set include actually more measures and have more stringent documentation requirements. These measures, again, they don't have any thresholds. You just want to score as high as you can on them to make up the remainder of the 50 points available after you've achieved 50 points from the base score to cap out that category at 100 points. And don't worry, we will go over these new and updated measures next. I will tell you the same advice I'm telling all of my clients that I'm currently working with who have upgraded to 5984 and can't decide what to report on. Have both programs added to the HQM and run both reports. You can always use the transition measure set as a safety net for this year and track your stage 3 measures to try and get 100 points simultaneously. Just because you've upgraded does not mean you have to report on the stage 3 or 2018 measure set. You have the option still. And yes, there is a 10-point bonus available for those who choose to do stage 3, but a lot of times I'm noticing that even with that 10-point bonus added in, clients are still scoring higher using the modified stage 2 measures or that transition measure set. And truly, there's nothing wrong with waiting another year and reporting using the transition measure set if you're scoring higher. Now, you may have noticed looking at the stage 3 measures, There were some measures that stayed the same from the transition set. There were also measures that maybe kept the same name, but what most people don't realize is that the workflows were changed to get credit. And these are what I'm calling the updated measures, and they include patient education and secure messaging. So again, this is only for stage 3, but this patient-specific education, providers must now do 2 steps. They must select education from the recommended search criteria box using HealthWise, and then also send the document to the portal. So the big thing here is education has to be suggested by the EHR. So that's why it needs to be selected in that recommended search criteria box. And then saving the education to the chart or printing it's no longer going to count. It will only count or increment your numerator if you actually send that education to the portal. This, I think, is huge for clients who depend on patient education as a high number to fall back on, especially if it's an integral part of your workflow already. I had clients who are running their 2018 ACI and 2018 transition ACI reports side by side this year. And on the transition report, they had almost a perfect 100%. And then on the stage 3 report, they almost had a 0 for the same measure. This very minor workflow change will most likely have a big impact on practices. Next is secure messaging. So providers must send messages, documents, or medication refill requests to the portal. However, once you upgrade to 5984, you're going to have to make sure that the contains clinical information checkbox is checked. And that's when you're sending a new message or replying to a patient message. So I will note this is actually checked by default in the EHR when you're composing a new message, but it's not checked by default on the PM side if you're ever sending anything from there, or when you're replying to a patient message. There are HQM settings that should be defaulted to checked when replying to messages. We're actually going to go over these settings in the next section, but this is why it's important. If those secure message types aren't checked in the HQM, you're not going to be getting credit at all when you reply to a patient. And really, these are really the kind of facts and bits of information that really drove the creation of this webinar. There are so many little nuances that I've picked up working with clients in our MIPS that aren't found on the CMS website or within NextGen's white papers. And I really wanted to take the time to share them all with you and hopefully try and make it easier to earn a positive incentive this year. Next, we actually have our new measures that were added for stage 3. Now, I put this measure first and on purpose because it's a bit of a hybrid between a new and an updated measure. Technically, it's new, and it's called Clinical Information Reconciliation, but it really is just updating the medication reconciliation measure to include more. So to meet this measure, providers must document all 3 areas of reconciliation in the KBM: medication, allergies, and problems. I've been hearing from a lot of clients, they actually hid the problems reviewed or no active problems checkbox. So again, comparing their 2018 transition report, they had 100% for MedRec, and then looking at their 2018 stage 3 report, they were almost again at 0% for this measure. Medications and allergies are pretty standard for office staff to reconcile, but the problems list is what's getting most practices, and your numerator won't increment at all unless you have all 3 for an encounter. And lastly, the 2 new measures, patient-generated health data and then request accept summary of care. So patient-generated health data, I'm telling most of my clients not to worry about for this year. You have enough measures to fall back on in the performance score you could focus on instead of trying to get this into place. This measure is really giving credit for having patient forms being filled out through the portal and then incorporated into the chart, or even using NextPen to complete forms and then electronically including them into the chart. There are more ways to meet this measure, but most involve either turning on new functionality or incorporating new technology that could probably wait until next year to focus on measure workflows such as the one we mentioned before this year. Now, this is the last new measure, this request accept summary of care, and I think it's extremely important because it's also a part of the base score for the stage 3 measure set. And that means if you're trying to report on the stage 3 measures, you need to have at least 1 in the numerator for this measure to even get credit. So this request accept summary of care is actually tracking transitions of care or referrals received, where CCDA was electronically incorporated into the patient's chart. So in order to get credit for this measure, there is actually an automated process in place. It's based on the HIE document import that can be used to capture electronic summary of care documents. NextGen also made it easier that when a patient only has one transition in their chart for that reporting period, and they also have a CCDA in their chart within that calendar year, the HQM doesn't require those to be manually linked. They'll automatically link it and automatically give you credit for that. Now, there is a manual process to actually increment the numerator by using the Transitioning into Care template. This new template is designed to support electronic requests or receipts of summary of care documents. So here's a screenshot of this new template found in 5984, and you can see here how the numerator workflow works. The summary of care document that contains today's encounter information gets automatically added to the request and or summary of care documents received grid. Through appointment scheduler, which is on the PM side, a practice can actually set up tasks to request documents about patients that are coming in. The task can be set to run on a nightly basis on the DBP based on appointments prior to a visit. So information will automatically populate in that top grid and is in the bottom grid if the encounter information is part of that request. But the document in the top grid will be selected by the user, and then the user just has to click Add Selected. When they do that, this should automatically check that bottom checkbox that states Summary of Care document received electronically, and then hitting Save and Close. Patients may also be excluded from the denominator when a summary of care is queried or requested, but none is available or received. So to exclude patients from the denominator to essentially not have them count against you, you would document summary of care requested or queried in external system by checking the top checkbox, which is the workflow on the right you're seeing. So by checking that top checkbox, you're basically excluding this patient from the denominator and they won't count against you. All right, so I know that was a lot of information, but I promise I really did slim that down to a just what you need to know basis to get you through reporting and on track for a positive incentive. The next kind of piece of the puzzle here to earning a positive payment adjustment is using the NextGen HQM to actually track and analyze your data. And that all starts with the setup and configuration of these programs. So I will actually turn it over to Lexi to go ahead and walk you through the different settings I go over whenever I start working with a new client. So Lexi, it is all yours.
Okay, thank you, Lindsay. So we're going to start from the beginning by looking at exactly what is the NextGen HQM. So the NextGen HQM, otherwise known as the Health Quality Measures, is a clinical data repository. So this is used for registry reporting of clinical outcomes and quality measure data. So the data for this repository is extracted from the NextGen report server. This allows report generation that's used for performance-based incentive programs. So some examples of these programs are the Accountable Care Organization, or ACO, the Ambulatory Surgery Center, or ASC, the Comprehensive Primary Care Plus, or CPC Plus, and then finally MIPS reporting. And that is going to include the Advancing Care Information, ACI, and Quality and Improvement activities. So with NextGen HQM being a registry and a data submission vendor, they can actually submit data for all three of the MIPS categories and CPC+. So NextGen has provided updates on the release schedule for the measures in the HQM for the 2018 reporting period. So the first update is the ECQM and ACO programs have been delivered. So there have been updates to the ACO program and how it functions in terms of reporting, and the ability to once loaded a practice population set into the system and being able to visualize that inside of the reports. The next release will be for the registry measures. So this release is going to happen in stages. So that first release is planned to happen on September 20th, and that's going to include as many measures as possible. The second release is due on October 11th, And then finally, if a third release is needed, that will happen around the end of October, and that's going to include any measures that may not have passed QA in time for that October 11th release. So now let's take a look at the various screens in this web-based tool. So first off, we're going to take a look at the HQM Home Page. So this homepage appears when you log into the HQM portal. And the user can see such information as your client site name. So this is important to take a note of this because when you are trying to communicate with the HQM team, this client site name may not necessarily match exactly your practice name. It's also going to show you any system messages or alerts. It's also going to show you the data processing status. So that section, it basically lets the user know information such as if you have a job that's complete or in progress. It's going to tell you the last process date or if no data has been processed. And then lastly, if you've logged into the portal previously and were in reports, you will see your latest and also any favorite reports, and that all is tracked at the user level. So periodically, the HQM will display announcements on the homepage. And these messages are important and it's almost always going to affect the end user in some way. So a lot of people might tend to overlook these. You know, there's a lot of alerts. You may not have time to scroll through all of them, but NextGen did color code these alerts to try to make it a little easier to understand. So if an alert is blue, like the one that you're seeing in this screenshot we have, that contains general information and or deadlines. If it's green, that means it is related to product appointments and or updates. And if it's red, it means expected downtime. So as you can imagine, these messages are even more important during that submission period because those downtime and deadlines, they're important to plan for, and any updates could contain fixes to a known issue that might affect you. So of all those components I just mentioned on the homepage, arguably the most important is going to be that job status. So when you're on the homepage, if you hover over that job status, you're going to see what's called a quick view panel. So that panel is going to show your job status in 3 steps. And the progress of the job is color coded. So green indicates that that step is complete. Blue lets you know that the step is currently being executed. And then white would indicate that the step has not started. This panel is also going to show the last data date and the number of days for any data delays. So this is really important to look at when you're submitting MIPS data using the HQM, as you will have to kick off a new job multiple times throughout the process. So this feature is going to tell you when the job is complete and also when it ran last. So if a job isn't running consistently, your reports won't update to accurately reflect your configurations. So that could hold you back from submitting. So lastly, not only on the home page, but on every page of the HQM tool, in the top right-hand corner, there's a magnifying glass icon. So this is going to allow the users to search for measure white papers. It's going to provide detailed information about program measures, all while staying within the HQM tool. So incorporating these white papers into the HQM, that's going to eliminate the need. User would otherwise have to open a separate browser, log into the Success community. So these HQM white papers, they can be a really great tool to use. They can help you when analyzing reports, or even if you have questions on measure specifications. For example, if you're unsure maybe how a measure pulls from NextGen into the HQM, these white papers can give you all the details. So before you can begin running any reports in HQM, you'll need to make sure that your portal is set up and that you have all of your programs configured. So in order to manage this configuration and access the portal and report settings, you will go to the config menu. So one of the first items under that config menu we're going to take a look at is the provider email NPI and TIN page. So on this page, you're going to want to verify that all the information for each of your providers listed here is not only complete, but also accurate. So the first piece, that provider HQM email, that is pulled from the provider master file and file maintenance. So if you find that an email is missing or maybe incorrect, the best practice is to go into that provider master file and actually make the update. But you also have the option to override that email address from within the portal. And that email is used by CMS and commercial vendors for several programs. The next piece is the NPI, and this needs to be verified in the portal. So when you first register and you go through that initial verification process with CMS, it will verify all of your providers' NPIs. However, when you have a new provider that's added after that initial setup, each of those NPIs need to be verified. So this is the same process for the TIN or the tax ID number. So whenever a new provider is added, that TIN will need to be verified. So depending on your practice, you also have the ability to assign one TIN for all providers. So let's say you come across where not all of your NPIs and TINs are verified. What you'll need to do is go ahead and click the verify NPI and or verify TIN buttons as needed. So you'll want to see that green column or green icon, excuse me, under each of those columns. And then as a note, if any of your providers did have unverified TINs, those providers would not show on any reports. So the next configuration page we're going to go over is practices. So a few things you can do from this page. You can enable and disable any participating practices. You can set what's called the credited provider. So basically that's just determining which provider on your encounters is getting the credit. For example, is it the rendering provider, the supervising provider, or even both? This is where you would set the practice level TIN. And you can also manage locations, providers, and places of service. So some key things that you want to look for on this page for this configuration is you want to make sure you have a TIN selected, and it doesn't say unselected. So if it does, it's going to cause an issue with any PQRS reports. You have all your providers checked that should be active for that reporting period. So this is where you would make sure that any providers that have left the practice are unchecked. You should also make sure all places of service are checked. And then lastly, you want to verify that the PHR enabled date is accurate and has that green check mark. So if you see an X, this is going to tell you that the PHR is currently disabled for the practice. So the next page we're going to take a look at is the ACI and the MU Settings page. So this needs to be updated to reflect promoting interoperability. So this page is used to configure things like the message or secure message categories, any exclusions, our transition of care options, and any self-attestation measures. The main thing to note on this page is the secure message categories. So as Lindsay kind of already mentioned, it's important that all of our message category types for your specific practice are checked. So what this is going to do is it's going to ensure that numerator is incremented whenever a user selects a category on a secure message that then gets sent to the patient portal. Next, we're going to take a look at our measures page. So any of these configuration changes that are edited and saved by the program and the practice. So when I say program, I'm referring to the quality reports that you run for MIPS. So under the MIPS program, there are 4 categories providers are required to report on in 2018. So we have that promoting interoperability, which was formerly ACI. We have quality, we have improvement activities, and then lastly we have cost. So for each of these categories, except for that last cost, they all have a corresponding program within the HQM for either individual or group reporting that must be configured in order to report on. So that last category, the cost category, is automatically captured by CMS, so it doesn't require anything additional for the providers to report on it. So when you make any of these configuration changes, the first thing that you want to do is to confirm that you have a practice selected. So this is going to drive what providers appear. Next, you need to select the appropriate program for the list. The programs are grouped first by year, and then they're alphabetical order for each of the years. So now that we have our correct practice and provider selected, you want to go through and actually select your measures. So to add a measure for the PI, CQM, PQRS, or AI programs, you want to click the green plus sign up in the top corner. So on the Adding Measure screen that you see next, you would select the practice, provider, and any measures that need to be added. Once all of those measures have been selected, you would hit Complete. So from the Adding Measures page, users can actually hover over any measure to display the measure description. And then measure tags beneath the measure name are going to show for all program measures that will help with selection. Another source of helpful information on this page are these star icons that are located on some of the ACI measures. So these are going to indicate that that is a mandatory measure for the ACI category, and those will automatically be selected. All selected measures on this Adding Measures page will be in green and have a check mark. So on the same measures page, you also have the ability to remove all or just select individual measures for a provider. So in order to delete a measure for a provider, you would click the red X beneath the provider's name, and then you would need to click the red X on the next confirmation page as well. If you just want to delete an individual measure, you would actually select that provider and then click the red X next to just that specific measure. Okay, so now that we have discussed some of the basic configuration and functionality of the NextGen HQM, I'm going to hand it back to Lindsay, and she's going to go over some of our program-specific configurations.
Awesome. Thank you, Lexi. Those are some really important steps I think a lot of practices overlook. The biggest mistake a practice can make, I think, is to go right into trying to run reports without the proper setup and encounter errors that really could have been avoided by checking the settings and taking the steps you went over. So let's go ahead and take a look at each program configuration within the HQM that you'll use to report under MIPS. So we're going to start with the hardest category first and get it out of the way, and that's the Promoting Interoperability category. Specifically, we'll look at the transition measure set first. Now, I will say for this one specifically, it's a little bit easy because everyone should have the same measures added. It doesn't really depend on the practice. There are exceptions to this. So for instance, if you're claiming an exception for a certain measure, but in general, everyone should have configured e-prescribing. There are two options, include or exclude narcotics. Feel free to add both of them in the beginning, but when it comes time to submit, you only want to have one of these on your report. Then you have the HIE measure, timely access, MedRec, all the ones we're used to seeing. And again, like I mentioned, this measure set's pretty standard for everyone. However, if you're reporting under Medicaid or you're trying to claim an exclusion, this will change. If you're claiming an exclusion, you'll actually want to remove the measure. With the stage 3 measure set under the same category, the list gets a bit longer here, but it includes all 9 measures you see on your screen. Again, this only applies if you're on 5984, since that's the 2015 certified EHR technology and can actually support stage 3. If you're not on 5984, don't worry about this, since the HQM team actually can't even add the program to your HQM portal unless you've upgraded. Now, if you are familiar with MIPS and the program requirements, something unique to the HQM and new as of last year is the addition of these self-attestation measures. These were added as a result of the ability for the HQM to actually submit our data. So if you remember when you used to log into the CMS portal, you were prompted with a few windows that you had to click yes to even start the attestation process. These were essentially added as self-attestation measures that you would need to manually add to your report in the HQM portal. I do want to note these are found under the config ACI and MU Settings, and then on that self-attestation measure tab. Once you add these, they actually can't be removed by the user. You'll have to reach out to the HQM team in order to have them remove them on the back end. So you don't want to add them all on accident when you don't need them all. Like I said, these are extremely important because you won't actually be able to submit your data without them added on. CMS needs to see them. And then I just want to point out here too, you only want to add your specialized registry reporting or your syndromic surveillance or immunization reporting if you're participating in these. So with that measure under the transition measure set for this category being expanded to include any type of specialized registry reporting, this is where you'd go to add it to count towards your performance score. This is also where you would add any of the exclusions that you were looking to claim. So if your denominator is under 100 for the HIE measure, so that's sending a CCDA, you can actually claim an exclusion for this. Now, a quick tip here to kind of maximize your score. Even if you have less than 100 in the denominator, let's say you're scoring a 19 out of 20 on this HIE measure, I would not encourage you to exclude it because then it won't count towards your performance score. So as long as you're over 1 in the numerator, you're fulfilling that base score. And by keeping that 19 out of 20, you just earned a 95% or 18 points towards your performance score since that measure counts for double. So really, I'd encourage you all to only claim an exclusion here if you're showing a 0 in the numerator for that HIE measure. Now, to actually add a measure from this page, it's a bit different than what we're used to with what Lexi took us through. You're going to go ahead and click the measure. A window will pop up and you click Add, and you'll actually see a little message display across the top of the screen that says this measure has been added successfully. You can also make sure these measures were added by going to the very end of the ACI or Promoting Interoperability report, and you'll see them actually listed at the end of your report with a status of yes. I will note these actually won't show up until after the job runs, after they were added. So this is one of the reasons of why knowing how to check the job status on the home page is pretty important. So we are done with the ACI or Promoting Interoperability category under MIPS. We've gone over the program requirements. We've gone over the HQM configuration and settings, even some workflow changes for stage 3. But just some quick tips here to maximize your score in this category. 1, check who's exempt from ACI. Use that MPI lookup tool on the QVP website and determine if you're not only exempt from MIPS, but if you're exempt from this category specifically. So if you're a hospital-based clinician or an ASC-based clinician, you may not have to report on this stuff at all. If you're not exempt, though, understand how the measures are scored. This category is definitely the most complicated scoring-wise. You have a base score that's all or nothing and counts for 50%. And then you have your performance score. And each measure there is basically you're scoring out of 10 or 20 points and you're trying to score as high as possible. Understand how the HQM tracks your measures. You want to understand what is actually pulling in NextGen to increment your numerator. And if we look at these quickly, the HIE measure, sending a CCDA, is using NextGen Share to send that CCDA. It's actually hitting the share button that'll increment the numerator. MedRec, when you check that check mark next to medications reconciled. Patient education, when you go into HealthWise and either save the education to the encounter, if you're using the transition set, or if you send it to the portal. Timely access, this is actually when your office staff generates a token. View, download, transmit, this is when a patient actually logs into their patient portal account. And then secure messaging, really when you're sending anything to the portal, a document, a medication refill, education, or even when a patient reaches out to you. And then just the basics here of determining which reporting options best for your practice, group or individual. We didn't talk about this too much, but you want to consider the implications of group reporting. If you have any providers who are exempt on the individual level, they're going to be included in your group score. Also looking at a full year versus 90 days. You do have that flexibility this year. You still have 90 days to report on. So maybe run both reports and see what scores higher. And then lastly, maximize your opportunities for bonus points. You have the option to report an improvement activity for 10 points. I definitely recommend all clients doing that. And then again, also if you kept around that second registry under the Meaningful Use program, you're going to get an additional 5% for that as well. And then our last bonus point, obviously, gaining that 10% for reporting using 2015 CERT or reporting on that stage 3 measure set. And that's really the last thing to determine here is figuring out if you did upgrade, what's the best measure set to report on for your practice. So moving on to the quality category here, you already know the requirements. We went over that. What we're looking at with this category is you have the option to also pick which measure set you want to report on, either PQRS or CQM. The PQRS measures are going to be what's referred to as the registry submission method, and the CQM measures are going to be the EHR submission method. I will point out you cannot mix submission programs this year. That's been delayed till next year. So it's all or nothing, 6 PQRS or 6 CQM measures. So CMS publishes these deciles based on national performance. I actually included the link in the slide deck for you to access the 2018 benchmarks that were released. Basically, a clinician's performance is compared to the published decile breaks, which you see in the screenshot. Points are then assigned based on which decile range that data is located in, and it also depends on submission method. So what this means is you could have the same percentage for the same measure and receive a different amount of points depending if you use registry versus EHR reporting mechanism. You can see I highlighted 2 breast cancer screening measures on that screenshot. One at the top says EHR submission method, and the one below it says registry. So one's a CQM measure and one's a PQRS measure. If you go along those rows, you'll see for decile 3, so to earn 3 points, if a provider has, let's say, a 13%, and that's their performance they're showing on their HQM report. If it was a CQM measure, they would get 3 points. You can see if it was a PQRS measure, they would be below that 3-point threshold. So that just kind of shows you a real-life example here of how those differing submission methods work based on the decile breakdown. And then lastly, you also have that last column, which tells you if a measure is topped out or not. CMS did finalize 6 topped out measures, and this basically means that in coming years they'll be phased out and that they will possibly only earn 7 points maximum. So if you can see here on the benchmark screenshot highlighted, one of the topped out measures, even if you get a 99.99% on that measure, you're only going to get 4 points. If you get 100%, you'll get the full 10 points. But in future years, that'll actually be knocked down. So even if you get 100% in future years, you'd only get 7 points. So just something you want to watch out for. Now, this is, I would say, probably the most important slide I have for this quality category, and it's really my process and how I work with clients and helping them choose which measure set to report on. And that's the question I get the most from clients is, do I report CQMs or do I report PQRS measures? And it's different for each practice. So I know we are going to run over on time here a little bit, so I will encourage you all to stick around as I walk through this. We are getting towards the end here. I apologize for going over a little bit. I know we will be sending out a recording as well as a copy of the slide deck if you do have to leave, but I'm going to go ahead and keep going through the slides here to kind of show you my process and walk you through these last few sections here. So you may be wondering what my process is. This is the exact strategy I use. I always run both the CQM and PQRS reports with all the measures added to get a baseline. I analyze each report and then I highlight any measures with data. The key here is make sure you don't forget about inverse measures. Inverse measures essentially show a 0%, but that is essentially gaining you 100% for that measure. There should be a measure tag that is actually identifying an inverse measure, but a quick way I have found and what I highlighted in that screenshot is on that national benchmark column, it'll show a 0 as the benchmark, and that's how you know it's an inverse as well. Once you mark all the measures that are showing data, go ahead and pull up your benchmark spreadsheet from CMS and benchmark each one individually. So that means looking at your percentage on your HQM report, finding the measure using the correct submission method for that measure on the benchmark spreadsheet, and then locate your percentage in that row. Once you find it or the range that it's in, look straight up to see what decile that is, and that's the number of points you would get. Go ahead and mark that down next to the measure to keep track. Just a quick kind of important note here, again, just one of the things I've learned with working with clients, Your PQRS measures, they're going to match up perfectly. Your PQRS measure on your report will match the measure ID on the benchmark spreadsheet. Your CQMs will not, however. You will need to use a measure crosswalk to actually see the eCQM number and then the corresponding quality ID. So there is an extra step when you're actually benchmarking your CQM measures. But once you do that, you benchmark everything. You want to go ahead and identify any measures that are high priority or outcome. And those are going to allow you to have some bonus points. But after you go ahead, you pick your top 6 measures dependent on how many points they're giving you, and you add up your totals. Compare both your CQM and your PQRS report, and whichever one is higher, that's going to be the measure set you choose to report on. So it really is a time-consuming process. It sounds complex, and I understand that. I'm not going to lie to you. It is. But it also gives you the most control over your data to ensure your best bet at a positive incentives. So again, just some tips here again to maximize your quality score. Really, it's that first step of determining which submission method is going to result in a higher composite score. So taking the time to go through each one of those steps of benchmarking both your CQM and your PQRS reports and comparing them points-wise. Just some quick reminders of avoiding topped-out measures and maximizing opportunities for bonus points. Those are some things to keep in mind as well. This next category, the improvement activities, those earlier categories, promoting interoperability and quality, were kind of the 2 hardest and most involved in order to gauge what your composite score would be. The improvement activities is a lot easier. What I did here mainly is just walk you through the actual configuration of the improvement activity since it's a little bit different. It's going to be similar to adding using the green plus sign to add measures. You'll check the ones you want to include, set the schedule, and then click complete add measures. I just included these more for reference since this is a new program as of last year. Some providers may not have been used to it or may not have reported on this activity last year. You'll see it's the same thing that we saw for the quality program. You have little provider boxes, and those activities will actually show up underneath each provider individually. When you run your quality program report, it'll actually show up as a report, and it'll look similar to those self-attestation measures. It'll say participating, and then the status will say yes. The really important part here is actually when it comes time to submit, you want to make sure if you chose an improvement activity that gives you a bonus in the ACI category or Promoting Interoperability category to regenerate your report after you add it. This bonus will actually show up as a line item on your ACI transition report, and it'll also show up as a line item on your submission file. If you're not seeing those after you regenerate your reports, then you're not going to get credit through CMS. So make sure that you're getting the bonus points you deserve. And then lastly is the cost category. Again, the 2 measures we talked about. This is going to be 10%. We've already gone over this. I just want to reiterate this category doesn't require providers to report anything. Like I said, I tried to make the 2 more complex categories go first here, and then the 2 a little bit easier categories, HQM-wise, last, in case we did run out of time. So just a quick look ahead for 2019. Again, for your reference, these are just some great dates to keep in mind. The date we're coming up on here, October 3rd, is the MIPS partial participation deadline. That's essentially just marking the last 90 days of the year that you have to start your reporting period. So if you haven't had your strategy in place yet for the ACI category or Promoting Interoperability category, if you're still not sure which measure set you're reporting on, starting October 3rd, you need to have a good idea since that's the last 90 days coming up. And then another important date to note is December 31st. That Advancing Care Information or Promoting Interoperability hardship exception application window closes. So if you're applying for a hardship under that meaningful use category, you need to submit it then. Now, the year 3 proposals, I did want to mention, they're changing some things. The main thing is that they're expanding the types of clinicians that are going to be included next year. These include PTs, occupational therapists, social workers, and even clinical psychologists. They are also actually implementing the opt-in to participate starting in year 3. So if any clinicians maybe are under the low volume threshold and they can't participate this year, next year CMS is going to allow them to opt in. They're also adding a third component to the low volume threshold. It's not just going to be a dollar amount and number of beneficiaries. They're also adding number of covered professional services, and that'll be at 200. And then lastly, they're modifying the MIPS Promoting Interoperability category. And if we had enough time here, kind of the culmination of this ACI or Promoting Interoperability category here is this proposal for next year. There's no more base and performance score. There's essentially only 5 measures to report on: e-prescribing, send summary of care, accept request summary of care, timely access, and public health reporting. So you might notice only 1 measure is being carried over from that stage 3 measure set that requires 2015 cert. 1 measure. So you can see if this is finalized, why I keep encouraging clients maybe to not focus so much on stage 3, especially if they're earning a very high score on the transition measure sets, because we aren't even sure if they're going to be around next year. Don't get me wrong, if this isn't finalized and stage 3 stays, you will be ahead of the game. But why not get a higher score and maybe just focus on the 1 stage 3 measure that we spent the most time on today, request accept summary of care documentation. And that would actually be included if this proposal is final. So again, just food for thought. I always like to make sure I look ahead to the future for clients I work with to maximize their chances at an incentive while also minimizing the amount of work put on the practice and office staff. So again, lots of changes coming for next year. We'll likely know if this is finalized or not the first week of November, just based on prior rulemaking. And then with that last question here, why does CMS keep changing the program and making our lives extremely difficult? I can't really answer that one. All I can say is that we hear you. We're trying our best to make this easier on you by keeping you informed and offering assistance if you need it. So to wrap up here, the Medicaid meaningful use, I actually won't even go ahead and go over. I just wanted to point out there's a new report in the HQM. It's the Provider Summary NPI report. If you're reporting Medicaid meaningful use and not under MIPS, you'll want to use this report. Last year they were combined. They went ahead and separated it out this year. But I promise I am done throwing a ton of information at you, probably making your head spin. As always, if you're uncertain where your practice stands, please let I-10 help. We can always assess your current readiness and provide recommendations for you. If you're interested at all or want to learn more about us, please visit us at i10.com. Continue to sign up for these webinars. We usually don't go over time, I promise. But also consider we do have 3-tier fixed price macro packages available. Macro fundamentals is 10 hours for one-time fee. And then we have macro intermediate and expert to work on a monthly basis. But, we've made it to questions. I'm not sure how many of you are still on the line, but thank you for joining us today. I'm going to go ahead and turn it back over to Chelsea for any questions that you guys have.
Perfect. Thank you, Lindsay, and thank you, Lexi, and thank you, everybody, for hanging on and staying in there with us. We're going to answer all the questions we have. In fact, we only have 2 right now, so if you have questions, it's a great time to ask them. So first question, can you only get credit for stage 3 PT/ED by sending HealthWise education to the portal? Can you get credit for other types of education that is sent to the portal?
I can grab that one. Yep, so for patient education for stage 3, you can get credit for other types of education sent to the portal. I included the HealthWise example because that is what I would say about 90% of our clients do. There's 2 facets to this for stage 3. You have to make sure it's suggested by the EHR. So you'll need to look at the white paper to see how the other types of education are actually suggested by the EHR, but that's why you have to click it in that recommended education or search criteria box. And then yes, you do have to send it to the portal no matter what type of education it is. You can no longer print it or save it to the encounter. You will have to electronically send it.
Awesome. Thank you, Lindsay. And it looks like this might be our last question. We have a provider, and when I looked up their NPI on the QPP website, and it says they are not exempt individually, but included as the group of my practice. Can they still submit their own data as part of the group? I'm sorry, as not part of the group.
Sorry, Chelsea, go ahead and read that one more time for me. So they are not exempt individually?
Correct. They have a provider that says that they're exempt individually but included as a group at the practice, and can they still submit their own data not as part of the group?
Gotcha. Yep, so basically what that means is you're exempt as an individual and you're included for group reporting. If your practice chooses to report as a group, your data will be included. However, if that individual provider wants to send in their data to CMS, more power to them. CMS loves all the data they can get, but they're not going to receive a payment adjustment based on that data. So this voluntary reporting that they're calling it for 2018, CMS will accept the data and it'll essentially allow them to practice submitting the data, but it's not until 2019 that they actually have the opt-in to actually volunteer to submit your data for a payment adjustment in place. So they can submit it, they just won't see a payment adjustment if they do so individually. If they choose to report as a group, they will see a payment adjustment.
Perfect. Well, thank you, Lindsay. And again, thank you everybody for joining us. Sorry that this went over. Usually we try to time them better than that, but this was so much really jam-packed information that we felt that it was important to just push through. If you have any questions or concerns later on, you see both Lindsay's and Lexi's information up on the screen. Feel free to reach out to them, and I'm sure they'll be happy to answer your questions. And likewise, I'll be sending out an email within the next week with a link to the recording and slides. So if you think of a question at that point, you can always reply back to my email as well and find a way to get a hold of us, and we will get you an answer. So have a great week. Thanks for joining us, and let us know if you have any more questions.
Yep, thank you, everyone.